Good evening, everyone. My name is Cynthia Davis, and I'm an assistant professor in the College of Medicine and the College of Science and Health at Charles R. Drew University of Medicine and Science. I want to welcome you to tonight's webinar on the social determinants of health. This webinar is part of a quarterly series of health education and disease prevention webinars brought to you by the Bridge Builders Foundation and coordinated by myself and Mr. Wesley Scholes. The aim of tonight's webinar is fourfold. Number one, to define what are social determinants of health, to determine how we can reduce or minimize their negative impacts on one's health and well-being, to discuss what Charles Drew University is doing to address the problem of social determinants of health, and lastly, to discuss how our community and healthcare providers can work together to reduce the impact of social determinants of health. Our guest speaker tonight is Dr. David M. Carlisle. Dr. Carlisle has been president and chief executive officer of Charles R. Drew University of Medicine and Science in the Watts-Willowbrook area of Los Angeles County since 2011. Dr. Carlisle is a published author in health policy, quality of care, medical education, diversity, and eliminating health disparities. A board-certified internal medicine specialist, President Carlisle received his BA from Wesleyan University, his MD from Brown University, and his MPH and PhD in health services from UCLA Fielding School of Public Health. President Carlisle served as the director of the Office of Statewide Health Planning and Development for 11 years under 3 governors. Under his leadership, OSPAD released its first ever health disparities report and increased scholarship and loan repayment opportunities for health providers committed to practice in underrepresented and under-resourced and underserved communities. I'm going to ask you to hold your questions during Dr. Carlisle's presentation and place them in the chat box. At the end of his presentation, I will go to the chat box and have him answer as many questions as possible. Additionally, we have a webinar evaluation form we would like for all of you to complete before you log out of the webinar. Now I want to introduce Mr. James Breedlove, Director of the Bridge Builders Foundation.
Greetings, everyone. On behalf of the Community Health Disparity Coalition, which is a growing coalition of over 20 organizations, each of which does tremendous work in the community, I want to greet you, but more importantly, I am excited about this coalition because as trusted and credible messengers, we serve a vital role in empowering and educating the African-American community. And I am very excited about this platform that we can get this valuable information to our communities, to our young people, and hopefully save lives. So I'm excited. Greetings to everyone, and I'll pass it back to you, Professor Davis.
Thank you, James. So without further ado, I want to introduce Dr. David M. Carlisle.
Well, thank you, Professor Davis, and everyone with the Bridge Builders Foundation. It's great to be with you this evening. James Breedlove, great to see you again, and everyone else, thank you very much. Before I start, I do want to probably refresh you a little bit about Charles R. Drew University of Medicine and Science. Like in many ways, the King Drew Magnet High School, we're a product of what happened in the Watts area of LA in 1965. That led to the McCone Commission, commissioned by then Governor Pat Brown, which issued a report And the chapter in the report that is most relevant to our university is one that you see when you drive by our campus. You see it especially from the high school perspective, which says education, our fundamental resource. So we were created back in 1966. We're now 56 years old to combat some of the issues that contributed to the violence in 1965. Lack of education, lack of healthcare. And we've been doing the same thing for our 56 years of existence. And of course, continue to do so under the rubric that we consider ourselves to be a community-founded, community-originated institution. And I tell people at CDU all the time, if it wasn't for the people of Watts, if it wasn't for the 34 individuals who laid down their lives for the betterment of South Central Los Angeles back in 1965, our university would not exist. And we should always remember that. Our vision is excellent health and wellness for all in a world without health disparities. That is our target. That is our North Star. That is our fundamental guiding principle at the university. We're talking about the elimination of health disparities. And we intentionally use the word for all because you can't just eliminate health disparities for some people and not do it for everyone. Our mission statement in terms of how we go about achieving our vision is as follows. CDU is a nonprofit 4-year private university that is committed to cultivating diverse health professional leaders who are dedicated to social justice and health equity for underserved populations through outstanding research, education, clinical service, and community engagement. That basically tells you what CDU has always been about and what CDU remains about today. We're a very purposefully driven, mission-focused institution, and many students who come to CDU come to us specifically because of our mission statement. We've had a lot going on. Our campus has changed a lot in the past several years. One of the biggest changes is about to unfold with the opening of our brand new 4-year MD degree program, our brand new School of Medicine. That school is going to open, the dean told me, in 67 days. She's counting the days and she's probably counting the hours, but she's not telling me about counting the hours. But 67 days. We will have a white coat ceremony on August 19th. Everyone here is invited. You only get one first time ceremony of any kind. And so this will be our first white coat ceremony welcoming our new medical students to the new School of Medicine, August 18th. So that's kind of what's going on at CDU. I was talking about Xavier University of Louisiana earlier today, and or just a few minutes ago, and I was saying, it's our desire for CDU to become the Xavier of the West Coast. And in California, there's a big need for this. Especially for students from under-resourced, underrepresented populations and communities. Because California has a lot of big macro universities. But to quote one of our nursing students, and I'm talking about the University of California campuses, the CSU campuses, some of our large private universities like Stanford and USC. To quote one of our nursing students, some years ago when we were signing a MOU with a community college. And she was telling the community college students, why is CDU a school for you? And she said, I transferred to CDU from a California State University campus, won't say which one. I came to the CSU campus from a community college. And she was saying I have a lot in common with the students from the community college that were there today. And she said the difference between being at a CSU and CDU, and she was in our nursing program, is I could be walking across the campus at my former university with 30-some thousand other students. And I could get beamed up to the Starship Enterprise and nobody would ever know that I was gone until maybe the end of the, the period. And they'd notice that I wasn't there when they were taking roll. trying to see what students were left in the classes, things like that. I just wouldn't be missed. I'm a number. I was a statistic. I come to CDU, and everybody knows me. My dean knows me. I know my dean. They know me by name. I know the president. The president knows me. They know me by name. Not only do they know me, but they know me so well that when I'm having a bad day, they can see it. And they will not just see it, but they will come up to me and say, "You look like you're having a bad day. Is there anything that we can do to help?" And she said, that would never happen to me at a CSU, or for that matter, at a University of California campus, basically. And so, you know, that's the special sauce that that Xavier brings to the undergraduate world. And this is why Xavier is so successful at getting students into medical school. Because as soon as you say that you're pre-med, even before you matriculate at Xavier for the first time, they're already on your case. They're calling you, they're checking on you. And throughout your time there, they will not let you become an academic casualty if there's anything they can do to prevent it. Well, in our environment, especially for students that are already challenged with the lack of resources, they might be the first person in their family to go to college. That kind of support can be the missing ingredient needed to determine the difference between success and failure academically. And so we want to be that small, nurturing university here on the West Coast, focused on students from underserved, underrepresented populations to propel them through college and into the graduate health professions. That's one of the big things that we want to do. And that's what CDU is all about. So I just wanted to start out with that brief advertisement. Thank you very much for indulging me. And now I want to share some slides with you about the social determinants. Can everybody see this?
Yes.
Okay. Trying to get our slideshow going. Okay, here we go. Another little adjustment to make. Yeah, so social determinants of health. It's a phrase I think we've all heard before, and but it's one that's very important, especially for the communities of South Los Angeles. And you all know, I'm sure you've heard, you've talked about disparities in healthcare before. The SPA 6 area of South Los Angeles, essentially the same, has the worst healthcare outcomes of any part of Los Angeles County. For example, there are 8 spas in LA County service planning areas for healthcare planning. The county issued a report some years ago that looked at 20 health indicators. So across the 8 spas, you might expect each spa to be kind of a bad outlier on 2 or 3, and a good outlier on 2 or 3. As it turns out, SPA 6 was a bad outlier on 12 and a good outlier on only 1. That just shows how challenged the SPA 6 area is in healthcare and health, despite everything that we've been doing. Whether you're talking about diabetic amputations, whether you're talking about COVID-19, HIV, whether you're talking about stroke, kidney failure, cancer survival, et cetera, et cetera, et cetera. SPA 6 is still challenged today. And a lot of that has to do with what we'll call the social determinants of health. So I'm going to go a little bit wonky on you because I want to kind of read to you the sort of official definition of social determinants of health. This comes from the annual, the biennial CDC report, Healthy People. The most recent one is it has a goal of Healthy People 2030. They've been doing this for about 40 years, I believe. And so every decade we get a new Healthy People. Things haven't changed that much since this first started to come out. But here's the definition that's used for social determinants of health. So These things are the conditions and environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. So this is the official kind of, again, policy-oriented definition. Now, lots of people might go, okay, so what? What does that mean, basically? So I kind of took this definition and distilled it down to something a little bit more straightforward. But again, this is the official federal definition of what are the social determinants of health. The definition that I would propose to you all now is something affecting your health that has nothing to do with how healthy you are. These are things that have nothing to do with the real biology of disease. They can cause the disease to occur, but it really has nothing to do with your intrinsic level of health. You can be a perfectly healthy person and still fall victim to the social determinants of health. Another request for indulgence. I want to read this to you, so I will read it. It'll take a while. It comes from a friend of mine. This is Dr. Kamara Jones, somebody I met in medical school. She's now working for Morehouse School of Medicine, has been at the CDC, and has published papers, I think a couple of books, and is a frequent presenter on this topic, which is called A Gardener's Tale. And I'm going to use it to define these social determinants of health. Imagine a gardener has two flower boxes, one filled with rich, fertile soil, and another filled with poor, rocky soil. This gardener has two packets of seeds for the same type of flower. However, the plants grown from one packet of seeds will bear pink blossoms, while the plants grown from the other packet of seeds will bear red blossoms. The gardener prefers red over pink, so she plants the red seed in the rich, fertile soil and the pink seed in the poor, rocky soil. All the red flowers grow up and flourish, with the fittest growing tall and strong, and even the weakest making it to a middling height. But in the box with the poor, rocky soil, things look different. The weak among the pink seeds don't even make it, and the strongest of them only grow to a middling height. In time, the flowers in these two boxes go to seed, dropping their progeny into the same soil in which they were growing. The next year, the same thing happens. The red flowers in the rich soil growing full and vigorous and strong, while the pink flowers in the poor soil struggle to survive. Year after year, the same thing happens. 10 years later, the gardener comes to survey her garden. Gazing at the two boxes, she says, "I was right to prefer red over pink. Look how vibrant and beautiful the red flowers look, and see how pitiful and scrawny the pink ones are." This is a gardener's tale taken straight from one of Dr. Jones' publications in the American Journal of Public Health. But I have a question for you. Is the gardener's tale an allegory about racism or about social determinants of health? And I'll just pause and ask you all to maybe give me some feedback on that. You can go ahead and unmute yourselves. Professor Davis, what do you think?
I think it's both.
Well, okay, I think you just won the prize.
Oh,
Because I was certainly going to say it is actually both. The gardener is acting in a racist way, certainly, by preferring one flower color over another, yes. But the reason I selected A Gardener's Tale was not to portray the actions of the gardener so much as to portray the impact of the environment that the flowers grew up in. That poor, rocky soil that they were in is actually a metaphor for a social determinant of health. It just shows how your environment can impact how well you do, whether you thrive, whether you grow to be tall and vigorous and rich, or whether you don't survive or maybe are just middling. So yes, both racism and social determinants of health. And the soil, poor and rocky, is an example of what it means to be in a poor environment. You suffer as a result. So I thought at this point we would engage in a little exercise, and I would encourage you all to unmute yourselves. And I thought this exercise would be one where instead of making a bunch of slides and kind of going through this one at a time, I might just ask each of you to pick one of these social determinants of health. And I will explain from my perspective why it is a social determinant, how it is a social determinant, and what it means. And I'll pick on Professor Davis first again. Cynthia, which one do you want me to talk about first?
I think food would be good. Food.
Yes. Well, you drive through South LA and you hardly ever see a grocery store. You don't see a Sprouts. You don't see a Pavilions. You certainly rarely, I haven't seen a Whole Foods, et cetera, et cetera, et cetera. Let alone basically any sources of fresh vegetables. What you do see are a whole lot of liquor stores. You see a whole lot of fast food vendors, sometimes as many as 4 on every corner of an intersection. You don't see the food options that you can see throughout the rest of Los Angeles. You certainly don't see a lot of fresh vegetables. You don't see a lot of food providing fiber. You see a lot of processed bread, a lot of fatty meat, a lot of red meat. If you're a vegetarian, best of luck. It can get a little bit tough. So it's no surprise that diseases like diabetes, hypertension, stroke, other cardiovascular disease, even cancer, are probably pushed in the wrong direction simply because of the social determinant impact of the food that's available in South Los Angeles. If I lived in Watts and I wanted to go shopping at a Whole Foods, I couldn't begin to tell you how far I'd have to travel to get there. You all might have a better idea than I do. But I imagine that, especially in rush hour traffic, it might take you about 45 minutes to get to a Whole Foods market or Sprouts. So that's food. And food, the absence of good food in the community that we care about, is a major determinant of the health status of that community, without a doubt. This is one example of a social determinant. Who wants to go next?
I'll try just a couple, Doctor, that we're already working with you on. Air pollution and the environment, the indoor environment. We at Bridge Builders are looking at the possibility of establishing a program that we can give lectures on the downside of indoor air pollution, particularly with the high number of African-American kids with asthma. So that's one that we're placing significance on. And the other is we, in coordination with another one of our institutional partners, the SRO Housing Agency, you probably are aware that we've been trying to work with them to facilitate interns and residents at being in some of those facilities.
Yes, and certainly I'd like to follow up on that last point with you if we have a chance either afterwards or later down the road. Air pollution, of course, LA is probably the most has the most polluted air of any city in the United States. It's been that way for decades. When I was growing up, we lived in the Baldwin Hills, and I think there was a gas company tower that was, I think, is no longer present in Los Angeles. And it was only probably a couple miles away from the Baldwin Hills, right, maybe halfway between there and downtown Los Angeles. But on the worst days, you couldn't see it. I certainly remember that. I remember as a young child with asthma, thinking, why can't we get rid of these awful school buses with this diesel smoke? That was horrendous as far as I was concerned. I couldn't stand it. I couldn't wait to get off a school bus or get off a metro bus because of the diesel smoke. Even today, even though we've made great improvements in combating air pollution, LA remains the city with the worst air in the entire United States. And we still see the impact of air pollution. Air pollution is worst in South Los Angeles, Central Los Angeles. It gets worse even going toward East Los Angeles and the Inland Empire. There is no doubt, and we know this statistically, epidemiologically, air pollution is costing the lives of probably hundreds of Angelenos every year. I don't know if you all know the name Antoinette Yancey. I know Professor Davis recognizes that name. She was a friend of mine at the UCLA School of Public Health, and was a rigorously physically fit individual. Never smoked a day in her life. Developed lung cancer. And that lung cancer was probably from air pollution. She succumbed to lung cancer without having had as a single risk factor for it. Now we know that in LA, there's both external and internal air pollution, as you mentioned, Wes. And the internal pollution can be just as devastating as the external pollution. We know that some of the internal pollution could be related to radiation leaking out of the ground. Some of it can be related to tire dust from nearby freeways. It doesn't have to all be related to nitrous oxide compounds and hydrocarbons and ozone. But we find it in the air internally. Even when you have put down a new carpet in your house or maybe change the floor, you're releasing air pollution into your interior space. And I won't, the next thing I should mention, of course, is cigarette smoking. My mother was a long-time cigarette smoker, was able to stop smoking when I was a little kid. But no doubt her cigarette smoking probably contributed to the frequency of my asthma attacks, as it no doubt continues to do for many, many young children in South Los Angeles. So this air pollution issue is a broader environmental issue, whether it's outside or inside. That is what we would call a social determinant of health. Again, like Tony Yancey, has nothing to do with how healthy you are. If you're just exposed to it, it can take a toll on you. And this is a big example of what is definitely known as a social determinant of health. It's an example of what we're talking about. If I can segue, I'll even talk about water quality. And my youngest sister was a professor at the University of Michigan in Flint. And I went to visit her. And I noticed the Flint River, which looked pretty pristine when I was up there. And we even saw a beaver in the river. 2 years later, after they redirected their water source to the river in the city of Flint, everyone in the city who was drinking that water was exposed to toxic levels of lead. So toxic that nobody in Flint was really allowed to drink the municipal water. Many children developed toxic levels of lead in their blood and their bodies. Many people were inevitably, young people were permanently impacted by this water quality. But it's not just Flint, Michigan, which continues to suffer today. We heard about this in Jackson, Mississippi, pretty much the same thing. Many of you, when you drive from up the I-5 from between Southern California and the Bay Area or Sacramento. Many of you have stopped in a city called Kettleman City. It's where Tesla has a big recharging facility. In-N-Out Burgers there. It's probably the major stop on that route. Well, Kettleman City has a secret, maybe not really a secret anymore. It is a cancer hub. The rates of various types of cancers, leukemias, lymphomas, are very high in Kettleman City. Why? Well, it's probably because one of the biggest outdoor dumps, landfills in the state of California, is located in Kettleman City. And all that decaying material seeps down into the water table. And if you have a well in Kettleman City, you're probably drinking what other people threw away a decade ago. And if you're breathing the air, you're probably breathing dust that from the air that passes over that dump and that landfill, and contributes to worsened health status for the residents of Kettleman City. Again, the same person, if they grew up in Brentwood, their health status would probably be very different, but they grew up in Kettleman City, and maybe now they've developed a leukemia. So these two things are examples of environmental, social determinants of health. Who wants to go next? I can't see everyone, so just go ahead and jump in.
You had someone ask about gun ownership.
Yeah, I know this is a controversial topic, no doubt. I have 2 public health degrees, and from my perspective, the prevalence of guns in the United States is a major social determinant of health. I mean, we just saw the latest episode down in Texas, where a family wanted to basically go to sleep. It was late at night, almost midnight. The husband went outside and told the guy, "Stop shooting your AR-15. My kids are trying to sleep." He kind of implied, you can shoot it some other time, but look, it's midnight. We want to go to sleep. The gun owner basically said, "I'll shoot my gun anytime I want to." Walked into the house next door and killed, I believe the number was 8 people, including an 8-year-old, 5 people, including an 8-year-old. The issue with guns in the United States is not that we don't necessarily have more violence. We don't have more road rage. We don't have more fights between 18-year-old men. We don't have necessarily more anger than any other country. I mean, if we do, maybe you have a little bit more, I don't know. But we have a whole lot more guns. In fact, it's estimated that 40% of the total guns in the world are owned by Americans. 40%, even though we have only 5% of the world population. The result of that is that whenever you have an altercation, instead of trying to settle it thoughtfully, or even confrontationally, maybe with, pulling a few punches or whatever, it's very easy to reach out to a gun and settle a dispute that way, like this issue with the noise, or like the young lady who was shot when she turned into a wrong driveway up in Michigan, or the young brother who was shot because he rang the wrong doorbell. Somebody had a gun and they used it. So it's no surprise that the United States by far has more gun deaths than any other developed country. When you compare, say, gun ownership in the United States and gun outcomes to Japan, for example, and I wish I had the data to show you, but I don't. I mean, I could probably get it within 15 minutes. But when somebody gets shot by a gun in Japan, that's a big deal. The number of gun deaths in Japan, the entire country, that has about half the population of the United States, is typically in the single digits per year. That's because they don't have guns. Australia, also with a kind of a history of the wild frontier kind of development like the United States. I used to have a lot of handguns, and they basically, then they had a mass shooting, horrific mass shooting. And and Australia decided to change some of its gun ownership laws. Ownership went down, gun deaths went down in Australia. So that's why gun ownership is here. It has nothing to do with your health status, but it's a leading cause of death in the United States. In fact, among our pediatric population, less than the age of 18, the number one cause of death today, as we speak, is gunfire. It's not asthma, it's not cancer, it's not car accidents, it's gunfire for children in the United States. The number 6 leading cause of death for African-American men in the United States is death from guns that are shot by law enforcement officers. So this is why this is here as a social determinant of health as well. And we could save lives if we could impact gun ownership and control how guns are utilized more effectively in the United States. Again, a controversial topic. I'm just sharing with you some of the data that I've seen.
There's a panelist that would like to know, like for you to speak on stress and type of job.
Certainly. And my friend Kamara Jones, when she's not talking about planting flowers in the garden, is a leading stress researcher. And we now know, I mean, a lot of these things like disparities, you know, you talk to old timers, and we've known about disparities for decades in health. I read a novel out of the Harlem Renaissance, 1926 it was published. One of the little mentions in that novel was about health disparities. I was kind of shocked, but not surprised when I saw that. So fast forward to the 21st century, and we know that African Americans experience significant stress, and we've always known that stress is impactful upon our health status, but we really didn't have a way to measure it until scientists started measuring cortisol levels. Cortisol is a hormone that is secreted by the adrenal glands in response to what we would call the flight or fight syndrome. You're faced with a major challenge and you've got to react to it, and boom, your cortisol levels go up, and they empower you to sprint away, or they empower you to land a few punches and hopefully survive the encounter. As it turns out, we now know today that as a group, African Americans have higher levels of the stress hormone cortisol than average in the United States. And we now know that individuals with higher levels of cortisol are more likely to experience conditions associated with some tension or stress, like high blood pressure, for example. So stress is here. It's caused exogenously. There's no stress gene that anybody inherits. You take me, I like to kid my sister all the time, who used to live in Orange County. And I would say, as soon as I would cross over the what I used to call the orange curtain and get into Orange County, I'd feel my blood pressure numbers drop by 10 points because it's pretty mellow. Or when I take a vacation in Hawaii and I walk around and I notice the cops, but they're not paying attention to me. I'm not getting profiled. Those are relatively low stress environments, and they make a difference in terms of survival. So that's why stress is here. Again, an external factor that doesn't, you're not born with high stress levels. It's something you receive from the environment. What was the other question, sir? The type of job? Do I recall? Yeah. So let's talk about the type of job. And there's a slide later on about COVID-19 where we'll talk specifically about jobs in that context. But there's some jobs that are dangerous. involving, machinery. There's some jobs that are dangerous because you're working, after dark. There's some jobs that are dangerous because you might be standing on the side of the road and somebody's paying more attention to their cell phone than they are to you, and you get run over. There's some jobs that expose you to dangerous chemicals. There's some jobs that expose you to cigarette smoke. There's some jobs that put you in front of people that are yelling at you all the time.
Mm.
There are other types of jobs where, everything's mellow and, you don't have anything to worry about. Unfortunately, people of color are probably more likely, and again, we'll talk about this in the context of COVID-19 in a bit, to be in the former type of job than the latter type of job. You think about blue collar jobs versus white collar jobs, for example. Being a teacher, teaching, an honorable profession, very much underappreciated and not without stress, especially in our central city schools where student to teacher ratios are sky high and the resources available to teach are pretty poor. It takes a special type of person to survive in those environments. And I could keep talking about the types of jobs, but needless to say, the type of job that one has that may expose you to air pollution, tire pollution, gasoline, insecticides, can definitely contribute to your health status. For example, being a farm worker. Most farm workers are not working with organic crops. They're working with crops that may have been sprayed that morning, may have been sprayed the night before. So it's no surprise that they get exposed to insecticides and suffer the consequences, for example. So just examples of types of jobs. We know that employment settings are a major social determinant of health. Who wants to go next?
So Dr. Carlisle, sorry, I have an echo here. See if I can correct that. So I see in the comments, someone raised the challenge of, say, for example, folks who have to buy water bottles in order to have fresh water, which obviously impacts their income. So I'm wondering if you could maybe touch on the income as well as zip code.
Yes. Oh, no surprise. I'll do income and homelessness at the same time. The poorer you are, the less healthy you are. Analysis after analysis after analysis indicates that. It doesn't matter whether you've been hospitalized with an emergency, like having a acute heart attack, or whether you're trying to figure out about whether you can afford to pay for a visit to the doctor or put food on the table. The more your income goes down, it is well documented that the worse your health gets. At the ultimate extreme of homelessness, if you are homeless, your life expectancy is about 15 years lower than average. There's nothing else that I could put on this list, except maybe gun violence, that lowers life expectancy more than homelessness. You think about those individuals that we see who are out on the streets. It pains the soul to think about what their lives are like and what they're having to cope with. And they can't cope with it successfully, and they're dying. Life expectancy 15 years younger, earlier, because they're the most low income of all low income individuals. Conversely, as you get wealthier and wealthier and wealthier, your health gets better and better and better. In the COVID-19 pandemic, lots of people were ordering sushi to be delivered to their houses from 4-star restaurants because they could do it and think nothing of it. Others had to get out, get on a bus, go to a McDonald's and brave all of that because they couldn't afford to get sushi from a 4-star restaurant delivered to their houses. Of all these determinants, the one that is, I think, most traditional in any type of analysis about health is income. And it's not just true in the United States, it's true all around the world. I will say, however, there's data that the relationship between health and income may be stronger in the United States. I mean, in most of the world, it might be kind of like this. As your income goes up, your health gets better. In the United States, that slope is a little bit steeper than in many other industrialized countries. If we expand this or extrapolate this to zip code, and it's a well-known cliche now, your zip code determines your health. And we certainly know that that's true. Where you are, where you live, affects everything on this table, everything on the slide. It has a relationship to the type of job you have, the transportation you use, the amount of stress that you receive, your exposure to the possibility of gun violence. As you mentioned, having to pay for bottled water. Well, if the water coming out of your pipes is good, you don't have to pay, you don't have to spend that money. Again, if you live in Palos Verdes, you're probably buying bottled water because you want to, not because you need to. All these factors are related to zip code. And so probably the single factor that correlates the most with all of these things is your zip code as a proxy for much of everything else. Race and ethnicity. I have a colleague at another institution who many years ago did an analysis on where doctors work in California. And his proposal, his hypothesis was, well, doctors would go where the money is, like the bank robber. They'd follow the money. Which makes sense, and we all know that the wealthier the community, the more you see doctors and dentists and pharmacists. But it wasn't the dominant predictor. And this is the surprising result of this analysis. Doctors are more common in the less racially diverse parts of California, more so than they're more common in the wealthier parts of California. That analysis, to my knowledge, has not been repeated. It's a couple of decades old, but that just shows how powerful race and ethnicity are as predictors. I touched on your country a little bit. I will say one thing, you all know, no surprise. The United States is still, despite the Affordable Care Act, which, kudos to Barack Obama for what he did. He was like Sisyphus. He got the boulder up to the top of the mountain when lots of other presidents couldn't get that done. But we're still the only country where not everybody in the industrialized world, not everybody has health insurance. And even with the health insurance that we have, co-pays, deductibles, premiums are so onerous that lots of people are avoiding getting health care because they can't even afford to pay part of the bill. And we've talked about national gun ownership and other issues as well. So even the country that you live in is a factor. I'm surprised nobody has asked me about the word on the lower right corner of the slide.
June?
When I showed my chief of staff these slides this morning, that was the first one she asked me about. She said, Dr. Carlisle, I really like your slides, but I got to ask you a question. What is June? And I said, well, it's actually a social determinant. Has nothing to do with the seriousness of your illness coming into a hospital. But if you go to a teaching hospital with interns and residents at the end of June for any kind of condition, your outcome is more likely to be poor than if you come into that teaching hospital, say in April, March, or February. Why is that? Question.
Because residents turn over.
Precisely, Wes. Thank you very much for that. It's well known, in my world, that when you have people who were medical students just a few days ago, and now they're interns working without supervision. Or you have residents who are interns just a few days ago who are now making critical decisions with not necessarily constant supervision. This actually affects the health outcomes of teaching hospitals. And you can do a mathematical analysis which shows that death rates and complication rates go up in these hospitals in the month of June. There's also what I would call a Saturday effect. What's the Saturday effect?
Most hospitals will contract with part-time people to work the weekends because the regular, more experienced people don't have to.
Yep, absolutely. And, you know, there's a big difference between the way an emergency room looks on a Saturday night versus how it looks on a Sunday morning. If you have any choice whatsoever, don't go to an emergency room on a Saturday night. Wait until that Sunday morning. And you might actually be seen quicker than that Saturday night. You know, if you come in on Saturday night, it might be until Sunday morning before you're seen, unless you have a acutely life-threatening condition. And hospitals, yeah, do staff themselves with visiting staff, typically on weekends and evenings. So again, nothing to do with how sick somebody is, but it could have everything to do with their outcome. And again, staffing levels determined by things like financial considerations, congestion. This is another social determinant of health. Then there's the word politics. And I'll show you a slide in just a bit about politics as we start to wrap up. So thank you very much for helping me with this. Education is pretty much a correlate of income. The more educated you are, the healthier you are, with one exception, and this applies to income just as well. And I call it the Serena Williams phenomenon. Doesn't matter how educated you are, how successful you are, how wealthy you are. If you're a Black woman and you're giving birth, you are much more likely to die and experience maternal mortality, independent of your income and education. You can have all the advantages in the world and still experience a bad outcome disproportionately. So I promised we'd talk about COVID-19 and social determinants. I will say that, you know, early on in the pandemic, COVID-19 seemed to be a condition of West LA, the affluent communities in the South Bay, again, Brentwood, Bel Air. The reason was that COVID-19 seemed to be correlated with international travel, and that people who were getting off the tour ships and planes flying in from Japan and Korea and China are typically more wealthy. And we were seeing the first cases of COVID-19 among the wealthier populations. Well, people in public health were going, well, there's actually a tsunami out there. And, you know, like just in a tsunami, a tidal wave in the deep ocean, you don't even notice it, but it's out there. When it gets close to shore, it rears up and causes damage. We knew that there was a COVID-19 tsunami that was headed toward under-resourced communities. We just hadn't measured it yet. When we unrolled our first diagnostic tests for COVID-19, they were being done by people who had access to care, healthcare, insurance in wealthier communities. People in poor communities didn't have the same access. And again, the diagnoses were being made in the wealthier communities. COVID-19 initially seemed to be a disease associated with the high income areas, a social determinant again. But people were just saying, we're just not measuring it in the poor communities. You know, wait until we do. And sure enough, when we looked at COVID-19 and its impact on underserved, under-resourced communities, it was disproportionate. We've tracked data on COVID-19 in the United States, in the state of California, LA County throughout the pandemic. And certainly less affluent areas, communities of color, populations of color are disproportionately experiencing poor outcomes from COVID-19. And that's not a fluke. There's actually probably a reason for that. And it has to do with social determinants of health. Again, if you're a lawyer on the 20th floor of a skyscraper in Century City, I guess 20th floor is probably too low. Let's call it the 40th floor or the 50th floor. And you go home, you get in your car, go home, and again, order sushi from that 4-star restaurant, and they bring it to you. Your likelihood of getting exposed to COVID-19 is very low. Maybe you don't even go to the office. Maybe just stay home at work and again, have food delivered. But if you're a bus driver and you live in Bellflower, and every time you open the door of your bus, new people walk in, and some of them start coughing, and you go, what am I being exposed to? There was a celebrated case of a bus driver in New York City who one day, he basically said, one day this woman got on the bus, she coughed on me, she didn't bother to cover her mouth. 3 days later, he developed COVID-19. A week later, he was dead. That's just a story. If you work in grocery stores, or you're working at a restaurant where you can't help but interact with multitudes of public individuals, many of whom were infected with COVID-19, no surprise, you're going to get COVID-19. Well, the odds are much higher you're going to get COVID-19. So these social determinants, the type of job you do, having to take public transportation, having to go to work in a crowded, say a classroom, where we're more likely to encounter individuals from communities of color. These are social determinants that drive health disparities. And I think that there's a consensus among people in the public health community that these social determinants contributed to the disproportionate deaths from COVID-19 among populations of color. I don't know, I'll pause and ask if there are any questions about COVID-19 before I go on.
I have a question, Dr. Carlisle, since I'm still out doing COVID-19 education in the community, and the response from most lay people is that the COVID pandemic is over. There's nothing to worry about. They're not interested in getting boosters. What should we be telling the community? Even though it's not a surge right now, that it's still important to know your status. It's still important maybe not to be in large crowds. It's still important to wear your mask. People aren't wanting to hear it.
I will just say, Professor Davis, amen to all that. And we know, you just have to look at the data that's available on the front page of the LA Times or New York Times. We still have people coming down with COVID-19 every day. We still have people dying from COVID-19 every day. Now, fortunately, the rates of these things are a fraction of what they were during the peak of the pandemic, to be sure. But COVID-19 has not gone away. It's not going to go away anytime soon. It's lurking out there, waiting for innocent victims to come along, especially older people, especially people with conditions that predispose themselves to bad outcomes from COVID-19. There's no healthcare professional I know who feels that the pandemic has gone away. It's now gone into what we're starting to call an endemic phase, where it's going to be there for the foreseeable future and kill people for the foreseeable future. It hasn't gone away entirely. I second everything you said about the need for precautions. The first day that the newest generation of bivalent vaccines became available, this is 2 weeks ago, on my way home, I stopped off at my CVS walked up to the pharmacist and said, have you got the new vaccine? Have you got the vaccine? And she said, yeah. And I said, have you been giving shots? And she said, we just gave a couple of today. We haven't really geared up for it yet. And I said, can I make an appointment? Made an appointment, came in the next morning. I got my booster shot on the second day they were available. Because I, as a health professional with asthma, I don't want to become a COVID-19 victim. I'm not ready to go there. And so we're not over this by any means. And it is still, according to all the data, disproportionately impacting communities of color.
Thank you.
Dr. Carlisle, we have one question about discussing the perceived increase in cigar smoking among people of color and its potential connections to increase lung cancer. Is there any data or information that you could share amongst that? You know, the cigar bars and all of that.
Yeah, they're becoming more ubiquitous. It's kind of trendy. And to be sure, you know, people don't really smoke. Most people who smoke cigars don't smoke them with the intensity that most cigarette smokers smoke cigarettes. That's a good thing. The bad thing is cigar smoke is more carcinogenic than cigarette smoke. It's
Wow.
harsher.
Wow.
We don't have, however, good data about deaths due to cigar smoke because the numbers are very low. And probably where you find a cigar smoker, you probably also find a cigarette smoker as well. So it's kind of hard to tease that apart. But I would say affirmatively, from my point of view, you know, whether you're smoking hookah from those Mideastern tobacco devices that have become popular, you see a lot of them up in Westwood, for example, whether you're smoking cigars, not safe, not safe. Do not recommend it. Avoid it. So I took all the labels off this map. I don't know if you all recognize it. Dr. Davis, you may have seen this map, Professor, before, I don't know. But I'll ask you all a question. What is this a map of? What are we seeing on this map? This is a social determinant of health. Yes, Wes?
The concentration of the infections relative to the states, the red represents the highest proportion of infections or deaths rate. And it's clearly an indication that where you live will also be a major factor in how long you live.
I would not disagree.
I was
Yeah,
wondering
Professor Davis.
if it's a reflection of maybe obesity. That's the first thing I thought when I saw the South and how dark it is in the South in terms of obesity.
I'm sure that both of you are correct. This map could be a proxy, a representation of any number of things, including, you know, deaths from COVID-19. But this map is here for another reason. So we can talk about politics. These could be areas of the country where, say, Medicaid expansion after the Affordable Care Act was lowest, especially in the Southeast, but the Midwest as well. Yeah, these could be parts of the country where rates of health insurance are lowest. Yeah. These could even be parts of the country with the greatest concentration of supporters of Donald Trump. Yes. This is probably a political map. And you know, this northern part of California is actually, they like to call themselves the state of Jefferson. Because they invoke Thomas Jefferson as an original constitutionalist. I'm not sure Jefferson would agree with that. But basically they're saying, forget all those amendments. Forget the 13th Amendment, forget the 14th Amendment, forget the 15th Amendment. Let's go back to the original Constitution. Oh, well, maybe we'll allow the Second Amendment about gun ownership, but all those other amendments, we want to be strict about the Constitution. So this could be a map of politics in the United States as a social determinant, because it's a map of diabetes, it's a map of obesity, it's a map about cigarette usage. What it really is, however, is different.
Wow. Oh, my goodness.
Now, the shocker here is not that life expectancy is lower in the Southeast for all the reasons we talked about. I'll even say, and I apologize, I love the state of Louisiana, especially that city of New Orleans down there. All that rich food and cigarette consumption, alcohol that goes along with it. Life expectancy is lower in New Orleans. It gets pretty hot and humid there. You eat all that food. You don't want to go outside and exercise. It's the last thing you want to do. Life expectancy is lower there. It's not just about life expectancy. The reason Michael Hilzek wrote this article that's referenced here just a few weeks ago is because for the first time since we've been tracking life expectancy in the United States, since the year 1900, life expectancy in the United States went down. It's never happened before. That's a really bad harbinger for the future. Again, this is a country, we're the wealthiest, most powerful country in the world. People around the world, if they could live anywhere, most of them would want to live in the United States. They'd want to come here. But we're not doing so well when you look at our healthcare. And so for all the reasons that we cited, including, and I'll just come back to the social determinant of politics that prevented our Medicaid programs from expanding, that has stood in the way of COVID-19 vaccines, especially in these areas of the country. Life expectancy has gone down and it's taken the life expectancy of the entire country with it. And there are disparities. On average, I think life expectancy went down about 1.7 years in the United States. For African Americans, it went down over 3 years. And I believe for Latinx individuals, almost 5 years during the COVID-19 pandemic. But it's not just about COVID-19. It's about cancer. It's about stroke. The stroke belt is right there in the deep South. It's about diabetes, et cetera, et cetera, et cetera. A social determinant of health, geography. So it's unfortunate when we talk about all these things, the truth is they're all amenable to policy. Every one of these social determinants of health, we can do something about. The question is, do we have the will? It's not about the resources, but really do we have the will to intervene to do something about them? Because they shouldn't exist at all. And again, there are many countries that have many fewer social determinants of health than the United States. Again, the good news is if we focus on them, each one of them can be addressed. We can lower the amount of indoor pollutants that come out of new carpet, for example. We can change the composition of those pollutants. We can have an impact on air pollution. We can fix water supplies, et cetera, et cetera. We can do something about all these things. And so the real kicker about this webinar is keeping our pedal to the metal, working like Professor Davis to do something about each of these social determinants. I just want to comment, we lost a giant of an individual just a couple of weeks ago, Dr. Wilbert Jordan, a renowned, internationally known physician working in the fight against AIDS and HIV. He probably did as much as anyone to basically say, like COVID-19, HIV/AIDS is a condition that is a danger for the African American community. I just want to note his passing and dedicate this presentation to his memory. He was a faculty member at CDU. He retired, he became a professor emeritus. And he called us the day before he passed away
Wow.
to advocate for students at the National Medical Association annual meeting. That's the kind of guy he was. So I just want to note that we lost a giant just a couple of weeks ago. So that's the end of my presentation, and I will take any other questions that you have.
Well, thank you, Dr. Carlisle. I mean, this was just so informative and eye-opening. Most of the questions you answered throughout the course of your presentation. I don't see any new questions in either in the chat or under the Q&A section. Does anyone have any questions?
Yes, I have one, Cynthia.
Okay.
It's not quite a question, but maybe a statement like to share with Dr. Carlisle. Dr. Carlisle, Bridge Builders is beginning now to be able to show examples of some of the influences that it had, 10, 15 years ago. So because there are now students in the workplace that were at one time scholarship recipients, okay? Secondly, probably in a few years, we'll be able to see the impact of the STEM students who are participating in the STEM programs. Cynthia has been helping us, in particular, plan for yet another place. We would like to design a longitudinal study or similar study to, in the future, be able to measure the impact of sessions like this. And I think she may already be talking to that. And then on a longer term, I know she has mentioned to you in particular that we ultimately would even like to do some trials so that maybe 50 years from now, someone can look back and say, because of X or Y happened. And we certainly would like to maintain our relationship, the relationship between Bridge Builders and the school to do that type of work.
Yes, and Wes, as you're speaking about Bridge Builders, I'm admiring your screen background there, showing the Golden Gate Bridge.
Oh yeah,
and it's quite an analogy. I think there are some opportunities. I don't think we've Professor Davis, you've been at CDU longer than I have, and probably have thought about this more than I have. But we have a program at CDU called the Saturday Science Academy, and this takes young people as early as the age of 4 and goes all the way through high school, brings them on our campus, and basically inculcates them with the idea you can be a healthcare professional. We give them a white coat and call the 4-year-olds doctors. And when you say, here's Dr. Johnson, Dr. Rodriguez, you see a light going off in their eyes. But we haven't studied, I don't think, the Saturday Science Academy, for example, to your point, Wes, as much as we could about its long-term impact. We know anecdotally, we have students that have gone to the Magnet High School from the academy. We have students from the high school in the academy. We have students in our programs at the university who've been in the Saturday Science Academy. But I would like I think it's very possible to think about an analysis that could compare longitudinal outcomes from the Saturday Science Academy and look at how it's contributed so that it can be emulated, which it is, around the country with an assurance that this is the type of program that we want to get involved in. When you think about, say, HBCUs and their impact on STEM productivity, for many years, I haven't seen the most recent data, but the most doctoral degrees in the sciences, for example, in the African-American population were held by graduates of HBCUs. This STEM impact is significant and important, because it's those STEM students that can then turn around and become the health professionals of the future.
Yes.
There's a question in the chat, but I also want to remind people in the chat to go to the evaluation link before we log out. But I'm going to read this question, Dr. Carlisle. I'm an undergraduate student studying human biology and society at UCLA. I'm very interested in the social determinants of health. I was wondering if you had any advice for joining research that can target studying these topics and advocating for change.
Well, one recommendation that I would make is maybe you want to email or even drop by and visit Professor Davis sometime soon, because this is exactly where she's working. She's on the ground, walking the walk of addressing this issue, and her public health colleagues as well. Again, CDU as an institution is committed to doing this. I would say one thing about for this undergraduate student. I don't know what your plans are for after you finish college, but think about getting a public health degree. I didn't get my MPH until after I finished my residency training, after I'd graduated from medical school. And when I got my public health degree, it showed the world of medicine and healthcare in an entirely different light. It was like I was looking at one thing from this direction. All of a sudden, I turned around and looked at it like that. It was totally different because I was exposed to public health. You think about public health, and all of a sudden you're taking care of thousands of people instead of one person at a time. In fact, I'll even quote a health officer from Yolo County up in Northern California. And he said, no, we're thinking about health backwards. Public health is not a subset of medicine. Medicine is a subset of public health. And as soon as he said that, I said, yeah, that's correct. It's all about the healthcare of the population. So I would say, you can follow up with me. My email address, I'll see if I can put it in the chat. But it's not hard to get in touch with me. I'd urge you to get in touch with Dr. To our faculty at the university as well.
Okay.
I had another question. The coalition is really focusing on getting, these kind of impactful information to the community, as credible messengers. But what kind of things would you recommend for community-based organizations? In our community, the grassroots organizations really are the credible and trusted entities. And how could we enlarge our role or be more impactful in getting the message and dispelling myths and stigma and those kind of things that seem to be barriers?
I'm on the board of the California Healthcare Foundation, and with an organization called Evaritis, and a researcher named Shikari Byerly and her husband. They did a survey of the health of African Americans, and published it. You can probably look it up online. I don't have a reference citation to share with you right now. One thing that it showed was really kind of interesting, maybe not surprising to people, but I think it was kind of a surprise to people that weren't expecting to see this. African Americans in California are
Folks
very
can now get pre-qualified with
African Americans in California are very sophisticated when it comes to health and healthcare. So sophisticated that we kind of put on armor when we go to the doctor, because we know that that if we don't have concordance between the provider and us as a patient, care quality can suffer. So we dress up. We worry about how we present ourselves. But general health knowledge and health concerns are very high. And I would say that is an example of the success that we've already had in terms of healthcare advocacy because of grassroots organizations. And I would say we need to continue this activism. We need to continue this articulation, because that's how we make change from the ground up, from the grassroots levels. When you think about the the Black Health Task Force in Watts, that's an example of a very successful organization that for decades has been effective. So these efforts definitely are impactful. I would say we just need to keep doing what we're doing already, doing more of it, spreading the word out, and being confident that we can affect change because of these efforts.
There's one last question I just saw. What would you state is the #1 contributing factor in the Serena Williams syndrome? Is it male dominant medical industry?
Well, because I have a PhD, I would have to say I'll have to disappoint the questioner, and I'll say from a multivariate perspective, there are a lot of factors out there that no doubt contributed. I don't know the actual details of what happened to our hero from Compton when she gave birth, so I can't really specifically comment on it. But I do know that, well, first of all, every African-American woman that I know of childbearing age, as much as they're enthusiastic about having a baby, unfortunately, the thing they talk about is their risk of having a bad birth outcome. That is a sad, tragic commentary on our healthcare system. The thing they worry about the most is whether they're going to be a victim of disproportionate maternal death. Again, it shouldn't be that way. And all too often, there's a ProPublica, and again, you can look at this up, you can Google it, a publication from a few years ago on maternal death. Most of these deaths are preventable. And there are a couple of common threads. And again, I can't talk about Ms. Williams' situation specifically. #1 common thread: patients feel like, and they are, ignored. Patients are pushing on buzzers. I'm in pain. I'm bleeding. Buzz, buzz, buzz. Nothing happens. There was that unfortunate circumstance that existed in the community. I won't name the hospital, but it was well covered by the media. A woman gave birth, had a cardiac arrest in a hospital bed. I was trying to get the nurses to come in and address her instability, her pain. Her husband had to do CPR on her after she had her cardiac arrest because the nurses didn't come in. These are horror stories. Another thing is many women who experienced the complications that led to maternal mortality knew that they were in trouble, but they kept putting off going to the emergency room because they didn't want to, or they couldn't pay for the co-pays and deductibles associated with that emergency room visit. In an era when we have much more health insurance around than we used to, co-payments and deductibles, the barrier of income, being able to pay for healthcare, are contributing factors to maternal mortality. So again, I apologize to our questioner. I didn't answer the question specifically. I don't, obviously the latter situation didn't apply to Serena Williams, but the former situation may have, I just don't know. And some of you may know more about what happened to her in the hospital than I do.
Again, we want to thank you, Dr. Carlisle, for spending this evening with us and just providing such relevant information about social determinants of health and what we can do to, impact the effect that these social determinants of health can have on us. It's not like we don't have the power or the control to change things. And I think what you said about public policy, impacting public policy and becoming advocates for change is going to make a difference in our community. Again, thank you. And I want to thank our audience for being here tonight. And we look forward to seeing you for our next presentation in 3 months from now.
Very much for the opportunity. Great to see everyone.
Thank you.
Take care. Stay healthy.
You too.
Thank you, Dr. Carlisle.
Most welcome. Most welcome. Thank you.
Okay.